Moving right into our next discussion. Sorry to our next two presenters. We've taken a minute away. We'll try to get it back for you. I'm very excited to hear from the next two presenters who are going to talk about ED-based interventions for substance use disorders, specifically opiates and alcohol. So I'm going to get right into intros for them so they can max out their time. First, our friend and colleague, Dr. Eric Anderson. Dr. Anderson is a physician at Highland Hospital in Oakland, California, and is a board-certified emergency physician and board-certified in addiction medicine. He is the Associate Research Director for the Department of Emergency Medicine at Highland Hospital, primarily focused on ED-based public health and substance use treatment disorder interventions. Prior to working at Highland, he was the medical director at Northern Navajo Medical Center in Shiprock, New Mexico, and I was considered myself very fortunate to be a co-new chief of an ED at the same time that Eric was. So Eric, great to see you. Thanks for joining. Eric's going to be joined by Dr. Catherine Hawk, another national expert in addiction medicine. Dr. Hawk is an assistant professor in the Department of Emergency Medicine and attending physician in the Yale New Haven Hospital Emergency Department. She's a former NIDA-sponsored drug use, addiction, and HIV research scholar and is board certified in emergency medicine and addiction medicine. She completed a residency training followed by a year of service as chief resident and research fellowship in Yale University Department of Emergency Medicine, and her primary research focus is on opiate overdose prevention with focus on harm reduction and linkage to treatment for ED patients with opiate use disorder. She's currently an investigator on grants from National Institute on Drug Abuse, Center for Disease Control, the Emergency Medicine Foundation, and the Addiction Policy Forum that focus on reducing opiate-associated mortality through data linkages, implementation, facilitation of ED initiation of buprenorphine, naloxone distribution, ED patient experience and reported outcomes, and dissemination of evidence-based practices, best practices for the care of patients with addiction. We are grateful they both took time out of their busy schedules to join us. Thanks, Dr. Anderson and Hawk.
Thanks, Sean. We're happy to be here. Dr. Hawk, do you want to go first or do you want me to go first?
Whatever you prefer.
Why don't you go first?
Okay. All right, let me pull up my slides. All right, let's not show you the end first. Okay, can you see?
We can see perfectly, thank you.
Perfect, thank you so much for having me. It's really an honor to be here today. I'm so excited to talk to you, and just in case we don't get to things there, we're going to cover a lot. There may be questions. My email is at the end, and certainly feel free to reach out at any time. So I don't have any conflicts of interest. I do have some grant funding. So the opioid epidemic is certainly, we very much know the extent of the problem. This will not be news to any of you. You've certainly seen, are aware of sort of these large, huge increases in opioid-associated mortality, particularly in the last 10 years, largely responsible or largely attributable to increases in synthetic opioids, specifically illicitly manufactured fentanyls. We also know that this is, certainly something that is also very much seen in sort of the American Indian and Alaska Native population. This is data from 2018 National Survey on Drug Use and Health. This is a telephone household survey of folks that are 12 and older. And the 2018 data, they found that almost 100,000 folks endorsed opioid misuse, about 5,000 endorsed heroin, and others, around 3,000, sort of a combination of prescription pain medications and heroin. So this is a graph that it's available on the CDC website. It shows sort of the course of opioid overdose over the course of really the past year. It's October 2019 through October 2020. And as you see that sort of the darker the state, the larger the increase in opioid overdose. And so as you can see, unfortunately, we're actually really lost a lot of headway and a lot of traction in many, many states sort of during the past year. So we know that treatment works. So methadone, which is a full agonist, and buprenorphine, which is a partial agonist, are medications that are approved by the FDA for the treatment of opioid use disorder. They have long-standing clear effects, opioid use, increased treatment retention, and we know that they actually work quite well, even if you can't provide sort of the Cadillac of psychosocial treatment and other interventions along with them. We know that there is sort of associated with a decreased risk in substance use. There's less viral hepatitis, HIV, and IV drug use complications. There's less risky opioid use, less overdose, less legal consequences, and really there's also data that shows that there's, folks in general are more able to have sustainable relationships, to do better with employment, and to sort of go about their day-to-day medical problems and engage with the healthcare system. So this is a report that was put together by the National Academy of Medicine. It came out in 2019 and is not so subtly noted, entitled Medications for Opioid Use Disorder Saves Lives. You can sort of see the list on the right. I'll just go through it quickly. There's a lot of evidence that shows that addiction and opioid use disorder really is a chronic treatable brain disease. We know that there's changes in the fundamental changes that happen in the brain, which take a really long time to change back. Even if you don't have ongoing drug use. And so that's part of what these medications help treat or maintain, is sort of the ability to engage, without craving and things like that. We know that these, medicines are effective. Long-term engagement is improved outcomes. That there is, I already talked about the fact that, there are certainly many people who benefit from behavioral interventions. I would not pretend that that is not the case, but we know that the idea that that not offering people treatment because you can't provide sort of a full scope of psychiatric services or behavioral counseling is not the right way to approach untreated opioid use disorder. We know that most people who could benefit from it don't receive it. There's fewer than 20% of people with opioid use disorder have received medications to treat opioid use disorder in the past year. And we know that stigma is a really big barrier, both for patients to receive treatment, and also a lot of providers just weren't exposed to it in the course of their medical training. And so there's a lot of, some mystery or a lot of questions around sort of how these medicines work. So we know consequences of inaction. This is a study that was actually done in Massachusetts. They used a linked data set, but essentially they looked at 17,000 ED visits for non-fatal overdose. It was between 2012 and 2014, so the data is a little bit old. But they basically looked at what happened to these folks over the course of the year. And so these are, otherwise largely young, mostly healthy people who were transported to the ED after a non-fatal overdose. And they found that, it was almost a 5% one-year mortality. So when you think about sort of diseases we see in the ED, particularly of young, otherwise healthy people, 5% mortality is actually quite striking. In this sample, only about 30% of patients actually received, even a month of medication for opioid use disorder in the year following. And they actually looked at sort of outcomes, and those that received buprenorphine had a 3% mortality, and methadone a 2.5% mortality. So it's almost a 50% reduction, for folks who had any exposure to treatment, much less sort of ongoing consistent. So this is a study that was done in our emergency department. It was published in 2015, and essentially it's a randomized controlled trial looking at initiating buprenorphine for people with untreated opioid use disorder in the ED. And so there were 3 arms. There were folks who had who received a brief intervention and got a standard referral, which is sort of the phone and the pamphlet, a facilitated referral, which is someone matching their insurance and making sure that, it was a treatment center that was a good fit for them, and also brief intervention. And there was a group that was randomized to receive buprenorphine, and they got buprenorphine and then a follow-up appointment sort of in a primary care clinic about 3 days after the ED visit. And so, as you can see here, the primary outcome that they were looking at was treatment engagement in 30 days. Because as emergency physicians, our goal is to get people, through the door to someone who can help manage their long-term disease. And so the folks that received buprenorphine were more than twice as likely to be engaged in treatment 30 days, and they also had less illicit opioid use at 7 days. So that's great in a randomized controlled trial. The question is, how do you think about actually doing this in the real world? And so I've been fortunate enough to be involved in, several implementation studies, mostly in sort of academic urban, but also in some rural critical access hospital in New Hampshire and other places. And so when you think about how you actually get this up and running, this is the 10,000 feet view. So you have folks that come into the ED and you identify them some way. They may be seeking treatment, they may screen positive, they may have a complication of drug use, or they may just be identified over the course of the visit. You can identify, diagnose opioid use disorder based on DSM-5 criteria. There's an MD-Calc app for that. There's also, and then you go through and calculate an opioid withdrawal score. And that scale is actually what tells you sort of whether or not you start the medicine in the ED or send them home with a prescription. And then you arrange follow-up. So this is just different words to explain. So the other key things that I want to point out that are sort of part of the pathway is, you obviously have to talk to the patient about their willingness to initiate buprenorphine. We certainly recommend a risk education and naloxone distribution, with possible or a prescription. And then, we'll talk a little bit more about how you arrange treatment following up. So there are some regulations around prescribing buprenorphine. It's important to know that anybody can treat opioid withdrawal with buprenorphine. You don't have to have an X waiver. You don't have to have any special training. So that is a thing that is legally allowed. There's also a thing called the 72-hour rule that it used to be that folks can come back to the ED for up to 3 days in a row to get redosing of their buprenorphine, sort of while you're trying to arrange follow-up. Obviously, getting folks into treatment within 3 days is not realistic in a lot of practice environments, certainly in many of yours. But that was sort of one option for at least trying to bridge people to a better plan or start a better plan. The good news is that just a couple of weeks ago, there was actually a change in the X waiver rules, where it was previously that physicians had to have 8 hours and advanced APPs. The PAs and APRNs had to have 24 hours of training and to apply for a data waiver in order to prescribe buprenorphine. That is now waived for anybody who only wants to treat up to 30 patients at a time, which is most ED providers unless you're doing an outpatient clinic. You still have to file a notice of intent with SAMHSA, which is this little website down here, and there's a little QR code if you guys know how to use those. But it should be, that process takes like less than 5 minutes. So that is, a way to make sure that you're able to prescribe moving forward. So this is an algorithm. Obviously in 15 minutes, I can't go through the whole thing. I just want to say there are many algorithms out there. They're posted online. I'm going to show you at the end how to find some of these if you have questions. But there are many algorithms out there. This is the one that we use. And essentially, if folks are not in withdrawal, then they can go home with a prescription. If they are, they can get a dose in the ED and then go home with a prescription to bridge into treatment. This is a sort of home induction. So if you're actually sending someone to start at home, we sort of have this like color flyer that you can print up and actually helps walk the patient through how to start the medicine. Also is helpful for teaching nurses and other folks how to use this. Also available, I'll show you where to get this at the end. This is our referral form. At the end of the day, this is all about trying to figure out how you can establish connections with your outpatient providers. There are many in many practice locations. There's been a rapid expansion in the last 10 years through SAMHSA funding. And so, there certainly may not be follow-up providers everywhere, but there are telehealth options. There are other options that are out there. And so, you want to figure out some way to sort of communicate and share patient information when you refer patients. This is just an example of what we use. So in order to sort of build a program, you need local champions, you need leadership buy-in, success stories, community partners. You want to think about what barriers you're going to have. Protocols are absolutely essential. Make it easy, don't reinvent the wheel, and think about the resources that you have. So these are just a couple of resources I want to go through. I think I'm okay on time, but I'm not sure. So yank me if you need to, Sean. So this is our website. That's the Yale website that we put up. It's got lots of resources on protocols and information around that. There's also a NIDA website on that has some scenarios, frequently asked questions, has some sort of interviews on how to motivate patients. Both of these sites have the algorithm. And then we've been working with the ACEP, Equal Network Opioid Initiative, to develop sort of a toolkit that includes webinars and resources and pocket cards. And I put the QR code there because it is not the most user-friendly website. It's a really long name, so it's not helpful to put on a slide, but you can certainly look for it, and lots of great resources there. So that is all I have for now. I do want to mention that I'm working with one of my residents who has sort of a longstanding interest in this area, and particularly thinking about how we can help improve care of folks that receive care in IHS hospitals and reservations. And so this was a survey that he developed to help try to figure out what resources might be helpful to pull together. So if you have an iPhone, you can grab the QR code. It's a $25 gift card. And the idea is really to figure out what resources might be helpful to help sort of support improved care around caring for folks with opioid use disorder. So that's all I have. Certainly feel free to reach out at any time.
Thank you so much, Dr. Hawk. And yeah, I just want to emphasize that last offer to reach out. Clearly, we haven't given enough time to this topic. We had just had a very full agenda this year. Really appreciate you coming in, covering a complicated but very doable intervention program for the vast majority of our EDs in IHS systems. So please, if you get a chance and you have the bandwidth, reach out to Dr. Hawk. And without further ado, want to turn over to Dr. Anderson for the balance of the time. Again, our apologies to both these speakers for not giving them nearly enough time to talk about these important subjects.
Okay, thanks guys. I'm gonna minimize this. Hopefully you guys can all see my screen here. Okay, so thanks. I'll try and go quickly. Thanks for the introduction, Sean. I'm Eric Anderson. I'm really happy to be here, especially alongside Dr. Hawk, who's a total expert in this area and knows probably more about treating substance use disorders in the ED than almost anybody. Currently, I'm in Oakland, California. Before that, I was at Shiprock at Northern Navajo Medical Center. So excited to be here. Thanks, Sean and Ken, for the invitation. Now, I don't have any disclosures, but I will talk about off-label uses of medications. So in this talk, I want to go over a few things. First, I'd like you guys to walk away with an understanding of the burden of alcohol use disorder in our communities, improved understanding of some evidence-based practices, and identify some ways to engage patients who have alcohol use disorder, regardless of what their treatment goals are. So some people will have abstinence, decreased alcohol use, or may not want to stop drinking at all. I also want to acknowledge that talking about alcohol maybe is a little bit of a downer. This is a text exchange between myself and a IHS ED director who will remain nameless. So I hope you guys can walk away with some tidbits for your practice. I was going to talk about a case here, but just for the sake of time, I think it's fair to recognize that the standard approach for most places is metabolized to freedom, right? So we see a patient who comes in intoxicated, maybe they have a little bit of mild withdrawal, some other complication, but lots of times, like the best thing we can do for patients is let them sleep in the emergency department until they're ready to go. But I'm going to say that we can do a little bit more than that. So let's try and do better than metabolize to freedom. So we're on part one of the talk here. And the first thing I'll talk about is the disparities, harms, and mortality from alcohol. Alcohol is costly to patients and to others. So this paper was from this UK Advisory Council in 2009, and they scored alcohol and drugs along this criteria of harm, ranging from the intrinsic harm from the drug itself to healthcare and societal costs. So using this approach, each drug was scored, and they found that among all the substances evaluated, alcohol had the most harm to others, that's in blue, in red, and then harm to the users, and that's in blue, compared to any other substance, including heroin, cocaine, meth, or tobacco. As we zero in on the harms from alcohol, it's important to note that there are some this is widespread across urban and rural communities. But we do see some notable disparities of disease burden and mortality. In this study, the authors used these de-identified deaths records and census data to look at an age-standardized alcohol-related mortality at the county level. So this map points out really high rates of alcohol-related mortality in certain geographic areas, including the desert Southwest and Alaska. So the states with the highest, the counties with the highest mortality were New Mexico, Arizona, Utah, Alaska, and the Dakotas. There are also some really significant racial and ethnic disparities in alcohol-related mortality. So this paper, again, looked at death certificates, and they found really large increases in alcohol-induced deaths from 2000 to 2016. The most noteworthy increases by race and ethnicity were seen in American Indian, Alaska Native communities, in both men and women, as well as in white women. And it was all across the age range, but the largest increases were for patients in their early 20s and up until their mid-30s. So this is a disease that predominantly affects a lot of younger patients, which can profoundly affect families. The authors from this paper also note that within the American Indian Alaska Native community, alcohol misuse needs to be considered within the context of historical trauma and exposure to other social risk factors. They also noted that the underfunding of IHS generally, particularly for SUD treatment and mental health, contributes to morbidity and mortality. This is the last slide I'll show about disparities. This is from Trends in Indian Health 2014. They found that among Indigenous communities in the United States, the alcohol-related mortality was 520% the rest of the population. It's really important to note when we talk about this that despite the stigma, American Indian, Alaska Native communities have also some of the highest rates of complete abstinence from alcohol. And most studies do tend to focus on patients living on reservations, which is only a fraction of the population. And there's significant diversity between tribes, as we know. So this brings us to 2020, the remarkable year that it was. And we all sort of feel that alcohol use has increased. And it has. This study was in JAMA Open relatively recently. And they found that among US adults, basically everybody was drinking more, and that there were more associated consequences and harms from alcohol in 2020. So this is going the wrong direction. We'll talk about some interventions, harm reduction, and treatment next. So first things first with treatment, there's a significant treatment gap for AUD in any care setting. Only 1 in 2 patients in the United States who have alcohol use disorder are treated, and only half of them are on medications for alcohol use disorder. So who should get treatment? What should it be? This might be new to some of us, but it is a spectrum of disease ranging from at-risk drinking or simply exceeding the safe drinking limits up to patients who have moderate and severe AUD. For the patients we're seeing in the ED that we note to have some complication, they're in withdrawal. We see them really frequently with intoxication and pancreatitis. The vast majority will have moderate or severe alcohol use disorder. And the recommended treatment for this population is a psychosocial intervention and medications for alcohol use disorder, which we've already established are really underutilized. I'm gonna go ahead and say that making the diagnosis of substance alcohol use disorder in the ED, I don't think you need to go to all the criteria. And if you do see a patient in withdrawal, chances are they do have moderate to severe alcohol use disorder. Essentially, to get there though, you have to have some of the following: withdrawal, tolerance, cravings, not cutting back, drinking in more amounts than intended, and then have continued use despite harms. So it's reasonable to say that this won't always be a medical mystery to many of us working clinically, and that many of the patients we're really concerned about will have moderate to severe alcohol use disorder. So let's break it down, talk about what this means for the ED. If a patient has moderate to severe AUD, or even if they present withdrawal, we should have a conversation with the patient that's patient-oriented, offer them treatment and medications for alcohol use disorder. In particular, which we'll talk about a little bit more, patients who are at risk for withdrawal or have withdrawal, we want to remember we treat this syndrome in the context of the disease. That is, to treat alcohol withdrawal in the context of alcohol use disorder. So Dr. Hawk alluded to this before, but SBIRT and brief interventions in the ED have the most robust evidence for their utility. It's recommended by ACEP as one of the core tenets for treating patients with SUDs. SBIRT is a brief intervention that consists of raising the subject of alcohol, providing feedback, sort of connecting the dots between their alcohol use and the ED presentation, enhancing motivation for change, and then negotiating a drinking goal and referral to treatment. So this has been shown to be effective for ED patients with hazardous and harmful drinking, even at 12 months, a whole year later after their ED visit. ED patients who have hazardous and harmful drinking who have this intervention will decrease their weekly alcohol use and heavy drinking days. Unfortunately, either studies didn't include these patients or wasn't effective for them, but this isn't going to work as a standalone intervention for most patients with moderate and severe alcohol use disorder. It's important to think about when we're talking to patients about this. We should be non-judgmental, approach this like you would any patient we're setting goals. I'm not totally convinced that SBIRT or these other brief interventions are a whole lot different from simply sitting down with a patient and being a good doctor and a good listener. It's important to recognize that decreased alcohol use rather than abstinence is a clinically important goal for a lot of patients, and we should do what we can to sort of help patients get there. The important thing is really to pick a goal. I think it's helpful to ask a patient what they think the biggest harm from their alcohol use is and come up with a goal together. And this usually involves just drinking less per week and keeping track of how much people are drinking. But for sometimes it means eating breakfast before they start drinking in the morning. Speaking of something as simple as eating breakfast, it's important to consider where the harms from alcohol use actually come from. So we know the answer. How do these patients die? They die from exposure, they die from trauma, they die from mixing alcohol with other drugs. So a lot of what we can do is talk about how people can reduce harms, and we can be really specific about this by asking patients about the circumstances of their alcohol use. Ask where they drink, who they're drinking with, do they drink beer or liquor, what other drugs are they using? I guarantee you can come up with some common sense advice for reducing harms from alcohol use for most patients. Speaking of harm reduction, quickly talk about this. This was a recent randomized controlled trial that came out from Seattle, but they looked at a harm reduction counseling intervention that was relatively brief alongside extended release naltrexone and compared it to referral alone, counseling alone, and they found that this strategy was the most efficacious way to reduce the medical and social harms from alcohol use among a set of patients, all of whom were homeless. So this approach of focusing on reduced alcohol use is a really increasingly important outcome when we talk about alcohol for patients in the ED or in any care setting. So let's talk about medications. These are the main medications available for AUD. I'm going to suggest that two of them have a lot of utility for the ED setting, naltrexone and gabapentin. Naltrexone is an anti-craving relapse prevention medication. It's an opioid antagonist. Many of you guys maybe are already using PO naltrexone. It's also available as a monthly depot injection that you can give in the ED, which we'll talk about. Naltrexone is effective at reducing alcohol use and heavy drinking days. Naltrexone has been shown to be effective in the primary care setting as well, making this sort of a good medication to potentially start patients on. It's also once daily dosing. Some of these other medications require ramps or up to 6 pills per day. The other nice thing is that it's also available in an extended release option. This is really promising for ED patients who might face some significant social barriers to care, including simply the availability or ability to go to the medication, go to the pharmacy and pick up medications. When you shouldn't use it, don't use naltrexone with any opioid use. It can dramatically precipitate withdrawal. I've seen it, it's terrible. Also, don't use in patients who have decompensated cirrhosis or have a significant transaminitis. Next, we'll talk about gabapentin. I think this is exciting because we can connect the dots between withdrawal and use disorder with gabapentin. We can treat alcohol withdrawal just by linking it. We can treat alcohol withdrawal smarter by linking it to treatment with AUD by using gabapentin. Initially, we need to treat severe withdrawal with benzos or phenobarbital, but then patients can be discharged with gabapentin rather than lorazepam or chlordiazepoxide. And the dosing recommendations here might be a little bit higher than expected, but this is what we're doing clinically. This is what's supported by American Society of Addiction Medicine. And the initial treatment when used for these patients does not require a titration. So you can just go ahead and start at 600, 900 milligrams PO 3 times a day. And then when we see them in clinic, we'll just continue it for patients in whom are responding. There are a few small RCTs that show either equivalence with lorazepam or another benzodiazepine for gabapentin. The monotherapy option is for patients, the monotherapy option for patients who have already had their initial withdrawal treated in the ED is totally reasonable. Patients in the gabapentin trials report less return to alcohol use in their withdrawal period, as well as less anxiety, less cravings, and less insomnia. While there's some potential for misuse, it's far less harmful than benzos. So don't use gabapentin for severe withdrawal and don't use it in renal failure. Those are the main reasons not to use it. So initially treat that severe withdrawal, and then this is sort of those patients who you were going to discharge with chlordiazepoxide or lorazepam. So part 3, I don't have a ton of time, but I'm going to quickly go through our experience at Highland. This is our algorithm, which is basically what we talked about. We're identifying patients, talking with them, offering them medications. We are offering patients either extended release naltrexone or 50 milligrams daily. We have this substance use program, substance use navigators that come up and they can meet patients in the ED. They're in clinic too. I recognize that this is funding and staffing dependent and sort of a luxury that we have, but consider looking into this for other funding opportunities. It's been totally critical to the success of our program. The other thing is barriers to follow-up. This can be hard, but a lot of these alcohol use disorder treatments can be done in the primary care settings. I know in Shiprock, we had a clinic where patients could go to for substance use treatment, but identify those places that patients don't have significant barriers to go to and develop relationships with them. Our initial experience has been great. We're not going to see follow-up rates like we do for opioid use, but we've had a lot of success in patients who are treated and following up in clinic and seeing them later. So I hope that this was a reasonable approach for how we can do better than metabolized apretum for patients with AUD. And at this point, I will stop. Thank you guys so much for the time.
Thank you so much, Dr. Anderson. I just wanted to let you know I've already gotten 2 requests in the background for your slides. So for both Dr. Hawk and Dr. Anderson, I think what we've heard about in the last half hour is the new standard of caring for patients with substance use disorder in emergency departments. The House of Emergency Medicine can do better in this regard. And thanks to the information we've gotten from these 2 national leaders who are pushing the envelope, I hope that everybody here considers implementing something like this in their ED. Ken.
Absolutely. My key takeaways being, and I'm sorry that sometimes I get flip on the chat, but is one, that we have viable, evidence-based, high-quality studies that are showing that we have treatments available. 2, that we have the ability in the emergency department to access these patients. These are our patient populations. And 3, I really like the paradigm shift from I'm looking to cure all substance abuse on the res to I'm looking to decrease harm to my community and to my community members. That seems like a better message to give to everybody, and one that seems like more attainable, and one that we could actually get instant gratification from on a daily basis when we see these patients. And I feel like what's holding us back is sort of that, maybe the policies, protocols, the training, which will get easier, and then certainly the follow-up. So I'd love to hear from our group, and we can share this offline too, about what those successful interventions and strategies have been for follow-up. And thank you guys so much for this compressed time. You guys certainly deserve more from us, and we'll circle back and have you on in future conferences for sure. Thank you.